Good afternoon, everyone. Greetings from ENET, Nurses' efforts to eliminate TB in India. Thank you all for joining us today. My name is Shima John, and I am moderator for this ENET. We are thrilled to have you here for our session on strategies of airborne infection in TB healthcare setting, personal respiratory protection. Before we dive in, I would like to give you all a brief overview of what we have planned for you. We'll start with a presentation by our nursing superintendent, followed by a question and answer session. We encourage you to participate actively. Feel free to ask questions and share your thoughts by raising your hands. Your insights and questions are invaluable for us. For the newly joined, this is our 17th ENT clinic, and we usually conduct this clinic last Friday of every month. But due to some experts' unavailability, we are doing it. A quick note on technicalities. Please keep your microphone muted unless you are speaking to minimize background noise. If you experience any technical issues, let us know in the chat. We'll assist you promptly. I request all of you to please join separately so that you can avail the certificates from us. If you don't join separately, you will not be getting your certificate. So use your own account to join this class. We are now the expert. I just want to tell you that the expert and both the presenters are from members from ETTI. We really thank them to be our expert and the presenter. Actually, TB Tuberculosis Transmission Initiative (ETTI) is a powering airborne IPC working group of Stop TB Partnership aimed to support the global TB fight against TB and other airborne infections by promoting development and implementation of feasible measures able to prevent and control airborne infection transmission. The mission of ETTI working group is to advocate for and lead operationalization of policies and expansion of evidence-based through research, education, training, and scaling up of effective implementation of airborne IPC. Thank you again for being here. Let's begin with the introductory remarks by our Director Ma'am, Dr. Manpreet Bhalla. Ma'am, we would be honored to have you deliver the introductory words to kick off our class. We would really appreciate if you would share your thoughts on ENT classes that we conduct, but we are open to any message you feel could be impactful. Ma'am, Dr. Manpreet Bhalla, ma'am. Good morning, ma'am. Are you there? Can you hear us, ma'am? Am I audible?
You are audible, Shima, but the voice is cracking. It's the voice is
not clear.
Voice is cracking on the other side also.
But we can clear you clearly, ma'am.
Ma'am, we are taking it up. We are just checking it.
Can you hear me?
Yes, sir.
Yes, sir.
Yeah, the sound is not from you.
But it's break.
Sorry for interruption. We are just checking into it. Ma'am, just give us 1 minute. 1 minute.
Yes, ma'am, we can hear you. Dr. Manpreet Bhalla. Ma'am, please.
Ma'am, you can start with your introductory message. Any remarks, ma'am, on meet the classes?
She's trying to at her function.
Okay, am I audible? Can you hear me clearly?
Yes,
Yes, ma'am.
we
Yes,
can
ma'am.
hear you clearly.
Okay, so good afternoon, everyone, and I welcome everyone on behalf of NITRD for this session of e-Niti today, that is nurses' efforts to eliminate TB in India. And the topic for today's session is strategies of airborne infection control in TB healthcare setting related to personal respiratory protection. So I think already 2 sessions have been taken. We know that airborne infection control, there are controls, 3 administrative, environment, and personal under which we airborne infection control. So today's topic is related to the personal respiratory. Know that all these infections are very important, and we have to take precautions like airborne infections. There are the precautions are very, and also as it has been taken last time, we need to assessment of the area. And again, for now, today's will be the personal protective equipment. As we all learned also during COVID times, so it is very important. And the main things in the PPE are the gowns, masks, and gloves. So these are the three things which have to be ensured. And I think the detailed will be taken by Dr. Anita. And over to you for further proceedings. Thank you.
Thank you, ma'am. Your presence and your work greatly enhance the value of our class. Thank you, ma'am. Thank you once again. Now, moving on, let me introduce our dynamic team here. To my right is Dr. Anita Rani Kansal, our presenter today. Ma'am is nursing superintendent of our institute, NITRD, and has been a master trainer for training of nurses in TB by ICN and has been recognized by ICN TB MDR TB project as a leading light in recognition of her outstanding contribution to the care of people with TB. Welcome to you, ma'am, to this session.
Thank you.
The expert for today is Dr. Grigory Volchenkov. Dr. Grigory Volchenkov is online today with us. Thank you for being expert, sir. Sir served as Chief Doctor at Vladimir Regional Tuberculosis Control Center in Vladimir, Russia since 2002 and retired in November 2022. Dr. Volchenkov managed to successfully implement comprehensive TB IPC program in TB control services of Vladimir region. Sir organized and participated as facilitator in several international BSc certification training courses in Vladimir, Russia. Dr. Volchenkov, currently an independent TB and airborne IPC consultant, is chair of NTB Transmission Initiative, working group of Stop TB Partnership. Sir serves as TB IPC expert for regional GLC of WHO. We welcome you, sir, to this e-Niti clinic. Welcome you, sir.
Good afternoon,
Good
everyone.
afternoon, sir.
The voice is much better now. I understand clearly. Thank you.
Our next expert is not here with us. He is Dr. Arthur Jensen. I think he's not feeling well, so he could not join us today. We wish him a speedy recovery. Now, moving on to the session, I request our presenter, Dr. Anita Rani Kansal, to please continue with the session.
Thank you, Shima, for the nice introduction and words. So today we will start, I think this is the 4th session and the last session on the airborne infection control strategies. In the last 3 lectures, we had seen the basics and the administrative control and the environmental control. And today we will have the personal protection, that how we can augment the airborne infection control with the personal respiratory protection. So just a recap that what all we have done from the last 3 sessions. As you all know, that tuberculosis is an infectious disease caused by Mycobacterium tuberculosis, and it mainly affects the respiratory system. And transmission occurs through the aerosols of droplet nuclei released during the cough, sneeze, or the speaking. And the droplet is the size is more than the 5 nanometer, and the droplet nuclei size is less than the 5 nanometer. Why the size is important? Because this is the main factor in the infectiousness. If the droplet size is more, then it will drop down to the floor, and ultimately it will be cleaned by the disinfectant by mopping, so it will be killed. But the size that the droplet nuclei, which is less than 5 nanometer, so that will keep on moving in the air, and with the fan air, it will keep on rotating on the same atmosphere, and whenever they get any host or susceptible host, it will enter the body of the host and will cause the disease. So that's why the size of these droplets is very important. And we have to work on that, the whatever is embedded in the air, that how we can reduce that bacteria, how we can clean the air for betterment of our staff and patients. So that we have already covered. Just a recap so that we can have a continuity of the this session. So ventilation is basically movement of the air, that is pushing and pulling of the particles. Because as I said that the bacteria will be in the air, now we have to see that how that air can be changed in particular that environment, preferably in a controlled manner. Why in a controlled manner? Because we want the bad air to go out and the fresh air to come in, because we know that the patients will be the source. Those who are the AFB positive patients, they will be the source of infection, and they will be continuously spreading that bacteria into the air. And we have to, in the wards, have to see that how we can dilute, how we can remove those bacteria out of the ward or out of any healthcare by controlling the movement of the air. So the basic principles are air exchange. Air exchange means that any room or any ward, the air has to be changed. So that can be calculated as the air changes per hour. There is a formula that we can calculate that how much of the air is being changed during 1 hour. So there should be minimum six air changes in any typical healthcare setting, and it should be more than 12 air changes per hour in high risk settings like our positive TB wards or the MDR wards. It should be more than 12, or in the bronchoscopies, high risk settings where suctioning is being done, X-ray rooms, closed rooms, microbiology labs, it should be more than 12 ACH. So like in the corridors also, that air exchange should be maintained, control of flow of the air should be maintained, clean air should be in and contaminated should be outside. So this is just giving a view of that how the direction of natural ventilation or the how we can place the patients and the staff. So the first one, that is first one is that you can see that healthcare worker in the green is the healthcare worker. And here is the patient. The wind is coming from the healthcare worker and it is going outside from the patient side. So this is a good type of flow of the air. So in all your wards, you can see where you are sitting, whether the air from the patient is coming to you or from the air from your side is going to the patient. So it has to be seen by you, because you can do the risk assessment at your area where you are sitting. Then this is the incorrect method. Here you can see that patient is here, wind is coming from this side, patient is here the healthcare worker is sitting and the wind is going out. It means all the contaminated air where the patient is sneezing or speaking, bacteria will come in and ultimately it will pass through the healthcare worker and will go out. This is not a good way of establishing your tables, chairs, or like settings in your clinics or in your wards. So because this in the picture, it's very easy to reflect this. But when practically you implement in your wards or in your clinics, it sometimes, because structurally it becomes very difficult to implement this. So we can have a good compromise like this. If structurally it is not possible to implement that, then we can have a healthcare worker at this side, patient at this side, and wind comes from this and it goes like this, so that the healthcare worker is not directly affected by the air from the patient. So this was all that we have covered. Just I'm repeating it so that we have interest in this. So now, what is airborne infection control? These are the measures to prevent spread, transmission, and acquisition of airborne infection between patients, from healthcare workers to patients, and vice versa. We can have healthcare worker also can give infection to patients. So this can be done by administrative controls, environmental controls, and personal respiratory protection. So in detail, we have already covered about the administrative controls are those where basically the things which are implemented by administration, such as making the OPD days separate for the TB and non-TB patients, making the separate wards for the TB patients and non-TB, making the separate facility for the HIV patients and TB patients, like this, making the health education posters, then segregation of HIV and TB area. Then this is creating, this is the MDR ward, creating a negative pressure ward where the staff is safe so that the air from the staff goes to the patient. So these are all the administrative measures where the administration takes action that what has to be done. Then these are the cough etiquettes that has to be taught to the patients. So this is just a separate sputum collection area. Previously, we were doing it in the center of our institute. Later on, it was shifted to an open air at the side last wall of the boundary of the institute. This is a training of the healthcare personnel in NITRD. We are doing regular trainings so that they are equipped with the measures to be taken in the wards. So what is the environmental control? Environmental control means that we are making some changes in our environment so that we can reduce the bacteria, or we can change the air so that the bacteria goes outside the ward, and ultimately in the sun it can be dried or it can be killed. So like the ward arrangements, this is MDR ward with unidirectional airflow. That means the air from the patient will not be coming towards the sister's room or towards the working station. So this is unidirectional airflow. That we can do by putting a suction at the end of the patient, as we have done in our MDR wards in the NITRD. By putting the exhaust fans, because exhaust fans will suck the air, so that will also can create the direction of the air. Then big windows, if you do not have exhaust fans or something like that, then these are the UVGIs that will kill the bacteria, because the air will go, hot air will go up, and ultimately with the movement of the air, if bacteria will go up and it will come into the contact with the radiations from the upper room, ultraviolet radiations, and it will be killed. So now we come to today's class, that is personal respiratory protections. So basically, you have to see that it goes hand in hand with the administrative and the environmental measures based upon the airborne transmission risk assessment. So this is very, very important that we have to see what is the risk assessment. Because in the wards you have to see how many positive patients are there, how many days of the treatment is there, whether the patient is taking proper treatment or not. And the risk assessment is also important to see whether we have to wear the gloves or the N95 or the PP, because just without assessing any risk, we should not wear all of the PPs also. That is also not a good way. So first we have to assess what type of patient is, what all risk you have from this, and accordingly we should use the IPC methods. So personal respiratory protection is imposing any filtering material in the respiratory path that will remove the aerosols or the particulate. So why we need these masks or personal respiratory protection? Because we want to limit the spread at the source. How we can limit the spread at the source? Source is, who is the source? Source will be the patient. So what policy from last, I think 10 years, we have made this policy that any patient who will register at the NITRD hospital, our hospital, we will provide them with a surgical mask with the registration paper. So that means at least some form of personal protection that you are giving to the patient and protection to others also. So needed to prevent the entry into the host also, because if we will give the mask, at least the major and the larger droplet more than 5 nano, that will be retained within the patient within the mask. So how can we achieve this? We have to implement our respiratory protection program, because it will go in hand with the administration. If the administration doesn't give that mask or doesn't make the policy, how we will implement it? So that's why these all things will go in hand, and we need to implement a respiratory protection program. Like in our hospital, we have made that all the patients who are in the ward, they will wear masks in the wards. So they are being given a linen mask. We have one tailor, and he's stitching, especially mask for all the wards. And each ward manager, she ensures that the patient is wearing those masks during their stay in the hospital. Then training healthcare workers on respiratory protection, that is also must. And most of our staff, whosoever joins new, we give them the training on all this TB and IPC. Then educating patients on the respiratory and cough hygiene, that is also very important. So like we have one whole department of health education. So we have one health education officer, and then there are many health educators under her. So they take this activity that they go to ward and teach them about the respiratory and cough etiquettes. And in the OPD also they create awareness. Then provision of mask and PP, as I said earlier. Now, what is difference between the respirator and the surgical mask? So this is respirator. This is respirator, and this is mask. So what differences we can see in this? The respirator is tight fitting. Respirator is tight fitting, forms a seal. It forms a seal around the mouth. And this is a loose fitting. You can see that air can come and can go inside. There is no seal in this. And filtration capacity, it filters at least 95% of airborne particles in N95. And surgical mask, this is effective for the larger, bigger aerosols, but is not that effective for the smaller aerosols. Then protection level. This respirator, it protects against the particle as small as 0.3 microns. And in the surgical mask, the protection is more particles having the size of more than 5 microns. The reusability, this respirator can be reused. This can be reused. And usually this is not reused, this is a single use. And it usually people are not very comfortable in wearing the respirator because it gives some resistance in the breathing. And usually surgical people prefer to wear the surgical mask because these are more breathable. And respirator usually protects the wearer. That's why we say the healthcare worker should wear the respirator, because it will protect the wearer, and surgical mask is that it will protect the others. That's why we give to all the patients and their attendants, we give the surgical mask, and to our staff we give the N95 mask. So all the respirators need to be assessed for the filtration efficacy, filter material, filtration methods, air velocity, pore size, fit and seal, breathing resistance, potential for contamination. So these are some of the things that we need to see for all the respirators. And when to have the personal respiratory protection, when caring for the patient with TB and other airborne diseases, while like now we can say only we have to wear the mask when we are caring for the TB or the other airborne infection diseases. I think in the general hospitals, we are not able to diagnose. So there are undiagnosed cases in the general hospitals. So I think in those hospitals also, at least they should also take some respiratory protection. Then while transporting or doing procedures on the patient, when suffering from a respiratory infection yourself, you should wear a mask. So this is just a simple face mask, that how we have to wear the face mask. Bring the mask to the face, place the metal nose piece over the bridge of the nose to ensure a close and comfortable fit. I think everybody knows it, people are using it. And secure by tying the top set of string behind the head, then pull the bottom of the mask to fit closely under the chin, then secure by tying the bottom set of the strings high on the head above the first set. So this was just how we have to wear that. First we have to clinch on the nose, then we have to tie the strings. This was about the face mask. So this is the case with the respirator. That also we will learn that how to wear a respirator. Now how to remove this? First remove the gloves and decontaminate the hands. Then untie the strings and remove the mask, handling only by the strings. You don't have to touch the main body of the mask. You have to take it out by the strings only. Then dispose the mask into the waste bin, that is yellow bag, and then you decontaminate your hands. Wash it out. So instruction for the use of mask: not to be touched by hand while being worn, and cover both mouth and nose. A paper or cloth mask usually gets wet in 10 minutes, so allowing the bacteria to pass. And it should be removed when it is wet, and removed by touching the strings only, as we have seen. So mask should never be allowed to dangle around the neck and placed in the pocket or on a clean surface. So now the steps of wearing the respirator. So I have with me Sakshi Arora, our nursing officer and CNE coordinator. She will be demonstrating the same by wearing that, how we have to wear the respirator. The first thing that you have to take, yes, Sakshi, please. First thing that you have to take the respirator in hand as shown in this position. The strings should, that is not seen. Everybody can see, I think. So these dangles, these are.
We are not able to see. We are seeing the slides only.
Oh, okay. Change. Yes, we will change it. Laptop मुझे दो. Slides. इसमें slides. So position the respirator in your hand with the nose piece on your fingertip, and cover the respirator in your hand, allowing the headbands to hang below your hand, and hold the respirator under your chin and the nose piece with the nose piece up. The nose piece can be seen by the metal. There is a metal tip on the nose piece. Then the top strap goes down, rest at the top back of your head. And the bottom strap is positioned around the neck and below the ears. So the second strap will go down below the ears, and do not crisscross the straps. Now you place your fingertips from both hands on the top of the nose clip, because you have to tighten it, you have to seal it. Slide fingertips down both sides of the clip, lower the nose area to the respirator to shape with your nose. Now you have to see the testing. If any air is leaking, you have to check the air. If it's leaking, then you have to again adjust your string, because it's adjustable. You can tighten it. So when you take the air, it should come from only from at the front side, not from the sides. And while exhaling also, air should come from the front only. It should not exhale, any air should not exhale from the outside. That is the proper way of wearing it. So usually fit testing, it depends upon your style, age, gender. Removal also we have to show. So because the poor fitting will add, if there is any poor fitting, it will allow the entry of air and microorganisms that we do not want. So to check the effectiveness, she can take a deep breath and see, you can see that some compression is there, and then she will exhale. It will come to the normal position. So any leak between the face and the respirator is potential entry for the infectious droplets, nuclei. Exhaled air may lead to the fogging of the glasses. If she is wearing the glasses, then you can check that if fogging is there, it means the air is leaking. So the size of the respirator also should be seen. We had this problem in our hospital that there was a big size of N95, and all the nurses, those who were wearing, it was not fitting at all. Then we have to report it and get the size changed so that it can be accommodated properly. So otherwise, how we can do the fit testing also, we can use some aerosols also which can be tasted. So that we can if any healthcare worker can taste the aerosol, so it means the respirator needs to be adjusted. So now how we have to remove it? Now you have taken the patient care, how we have to remove the respirator? So do not touch front of the respirator. It may be contaminated because almost you have taken the patient care, so all the bacteria or organism will be here. So you need not to touch it. You don't have to touch it. So remove by pulling the bottom strap. Now she will demonstrate that how it has to be removed. Remove by pulling. So you have to take the bottom strap first over the back of the head, followed by the top strap without touching the respirator. So now discard this yellow in the yellow bin and wash your hands. So these two things that you have to see, that how you have to wear the respirator and how you have to remove it. Slides. Now we will see a picture of how this ill-fitted respirator, because it's very, very important. You are investing in the respirator and then we are not wearing it properly. That will be more risky than not wearing the N95. So it's very important, if you are wearing the N95, you must know that how it should be fitted properly. So this you can see that the air is coming and going. So this is the poor fitted respirator. So the certified respirators means, because we have seen there are so many criteria of the respirator, there should be pore size, it should be, so there's some certifications also which will say that this respirator is okay, this is not okay. So it reflects a minimum of 95 reduction in 3 micron particulates in non-oily atmosphere. And herd protection effect of N95 is described in healthcare setting as prevention of one individual can protect a chain of individuals. As we have seen in the corona, that if one is infected, that it will give a chain of individuals will be affected. But if one is protected, it can protect so many individuals. The surgical mask protects the others from the wearers, and N95 respirator protects the wearer. This already we have seen. So this is one study that recently it was shared on our group, that the meta-analysis by Trisha et al. On the mask and the respiratory that showed strong and consistent evidence of airborne transmission of some respiratory pathogens can be controlled with the use of any respirators. So correct and consistent wearing reduces the transmission. Respirators are more effective than masking, helps preventing community transmission. Masking has social, psychological, and political influence when it comes at the community use at the community level. So now, what are the issues with the personal respiratory protection? We have seen that study says that this definitely provides some protection, and then if protection given to one person, it can be protected. So many people can be protected. But what are the issues? Why we are not using it? So one thing that it may be contraindicated few medical conditions. Some people are not very comfortable wearing this. Then the blind and deaf people may have problem understanding. In the corona also, it was a very difficult because the people have the PPE also, have the goggles also, have so many things that they were not able to communicate during the CPR or so. That was the issue. Then fogging of the goggles or the specs, acceptability also, because in India, usually mask we used to give to the TB patient. So it was well accepted that though anyone who is wearing the mask will have TB or some respiratory problem. So that was a notion. Usually TB patients also, when they used to reach near their house, they used to remove the mask and will put into their pockets because stigma was attached with the wearing of mask. So one good thing the corona has done that everybody was wearing mask and the mask has got some respect as to the previous status. So the cost benefit analysis also, because if cost benefit analysis also, if we are not benefiting from this, then why should we investing in the mask and the respirators? Because and the environmental impact also, because this will lead to non-biodegradable waste, so that we have to take care. That will be an environmental impact also. So accumulated dust or the microbes over the mask may reduce the effectiveness, and mask may affect the comfort, breathing, and the communication. And it's still a challenge. Even if we wear the mask with the all certification and all, it's still a challenge to filter very, very fine particles. So cough etiquette is also very, very important part of this personal respiratory protection. So all the patients or everybody, not only the patients, everybody should be taught that they cover their mouth and nose while coughing and sneezing, use tissues, turn away your face, do not cough, sneeze directly into the hands, better to cough into upper sleeves, discard the infective tissue in the trash bins, especially in the yellow bags, and wash hand with soap and water. That's for everyone. So this is just how we can encourage proper respiratory and cough etiquettes among the patients and relatives. We can put the post-visual reminders every now and then, like we have in our wards in the OPD. And we provide patients and the visitors with the supplies, provide with the mask that we are doing here, and mask for the protection to the staff. We should be providing the N95. So these are the some of the visual reminders that we have to put everywhere. These are also just an example of the visual reminder that how. So this is hand hygiene, also another portion of this, that you have to keep your nails short, do not wear nail polish, remove your jewelry, bracelet and wrist watches, and do not dry hands on the clothes or the uniform. So wearing gloves is not a substitute for hand washing. That's very, very important. So I thought, let me have one slide on this hand hygiene as a part of protection. This is just that how to wash hand. I think everybody knows it. And what is difference between hand wash and hand rub and how we should be doing it. But this is very, 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 very important. Everyone should be doing this. This is the 5 moments of hand hygiene. I think this also everybody knows. So this is just the supplies that how we should be providing in the wards or that soaps, alcohol-based drugs, masks, tissue, proper disposable areas, hand sanitizing stations, masks. So those patients, those who discharge, and I think we should teaching the airborne infection control how they have to do at home also. So precaution to be taken by the patient, that adherence to the treatment is must, as it will make the patient non-infectious in around 2 weeks. So this we have to teach the patient that adherence to treatment is a must, and they should cover their mouth and nose when coughing or sneezing. They should not be sleeping in the same room with other household members till they are positive, and refrain from having visitors in the home till they are non-infectious, and they should be in the ventilated rooms. Precautions to be taken by healthcare workers during their home visit, that they should wear a respirator while visiting the home of a patient with infectious TB disease or when they're transporting a patient with infectious TB disease in a vehicle, and collect specimen in a well-ventilated area away from the household members. Because usually when the patient is discharged, for the follow-up also sample is taken from the patient. So sample should be taken away in the open area, away from the other members. So what are the role? I think not only the role, it's all about nurses and nurses work, that how they have to prevent the infection in their areas. So first is risk assessment should have priority. You should be able to see how many patients of AFB positive, what is their positivity level, whether the air is changed adequately or not, how many relatives are with that patient, how many people are in close contact with that. So these all risk assessment has to be done by you in your wards. So evaluation of HIV status is also important, and that is a guideline. I think now every patient that is admitted to any ward is being evaluated for HIV status, and any HIV patient is being evaluated for TB. That is a national guideline. And ensure evaluation of patients with more than 2 weeks of cough for TB. And we should be separating the HIV and TB patients, that you all know that we should not be keeping the TB patients with near the HIV patients. Be up to date on the infection control practices, and be aware of the procedure that put HCP healthcare workers on the risk for acquiring TB infection, such as suctioning, nebulization, that we have to do with more precautions. Then use appropriate PP while caring for the TB patients, and ensure proper ventilation in wards with TB patients. And segregate hospital waste appropriately. Follow the guideline for safe handling of sharps, pills, specimens, etc. Educate the patient family regarding cough hygiene, adherence to TB treatment, maintaining good ventilation at home. Teach, train, and supervise junior staff, students, cleaning, and other staff to follow the infection control practices. So poor implementation of infection control policies put the healthcare workers at the risk of acquiring TB in health facilities. Broadly, we have seen that the infection control is at the 3 levels, but each one go in hand, and nurses have to play an important role at all these levels. So special thanks to Dr. Manpreet Bhalla, our director. She is very supportive and very positive about our sessions. Dr. Sanjay Gupta, today he was busy in some training of TB program, so he couldn't join us. So Dr. Rohit Sareen, an ex-director of NITRD, he was the first who was very keen for the airborne infection control and always motivated us to implement this. And all the members of our ETT and the experts of all 4 sessions, and International Council of Nursing who trained us for this, and CDC who trained us for the airborne infection control, ACO India, Shifa. She usually takes all the pain to send us the feedbacks and conducting these sessions. And our ENIT moderator, Shima, and CND coordinator, she helps me with all slides and all materials. I just give the idea, so she helps me with that. So thank you all. Thank you very much.
Thank you, ma'am. Thank you. Ma'am's presentation was superb. And the way she demonstrated practically how to apply, how to wear a mask also was very clear. Even a layman could understand. I think most of us are wearing in a right way, but many are there who are not able. They don't know how to wear it.
New staff.
New staff have joined recently, might not be knowing this, but now it has been showing it practically, demonstrating practically, we made it more clear. Thank you, ma'am, for this.
Thank you,
sir. Dr. Grigory Volchenkov, are you there? We can see you. Even though ma'am's presentation was super, but we would love to incorporate your expertise in it. Could you suggest any key point or any additional points which make this presentation more comprehensive and impactful? Sir, we can see you. Can you hear us?
Yes, can you hear me?
Yes, sir. Yes, sir. You're audible. So can you put any other insight? Okay, sir.
To hearing from Dr. Anita. and she presented very well as usual, and her talk was very comprehensive. I would like just a little bit stress the importance again of risk assessment. So we begin from the assessing the risk every time, every morning, every half of the day. And the respirators are actually for high risk settings. It's impossible to wear respirators 24/7 for sure in real life and in working settings. So in healthcare settings, our administrative control, our comprehensive airborne infection control program, infection control program, should be aimed to locate the high-risk procedures, high-risk patients in isolated areas. And if it's well done, we can use respirators only in the designated areas with the special marks. This is high-risk zone. This is the respirators should be worn here. But it's not always this way. So we have to assess the risk. The highest risk is unventilated or in poorly ventilated settings. The highest risk in the patients with respiratory symptoms without diagnosis, without effective treatment. So in some settings, we have to wear respirator. It's very important that respirator should be correctly donned, put on, and the respirators should be well fitted. Respirators should be certified according to the national or international standards. I see some questions about standardizations of respirators. It's really important to make sure that the respirator you use is certified. And we can discuss how it can be found if this respirator is certified or not. Also, the issues of valved respirators. We can see many respirators with valves. What are they for? What are they good? Do they actually provide any protection or not? This is important to understand. In fact, these exhalation valves, they let expired air, exhaled air, to leave the internal space of the respirators. So they provide some comfort. They reduce collection of wet air. They reduce the sensation of the hot and wet space under the respirator. So in some settings, when the very high incidence of respiratory infections, like it was at the peak of the COVID-19 pandemic, in case if the healthcare worker or wearer of respirator is infectious himself or herself, actually this can be a serious factor of transmission of infection, COVID-19, TB, or other respiratory infection. So we do not recommend to use valved respirators during the high incidence times on the peak of the epidemic. If we are not sure that all our healthcare workers are healthy, we should use only respirators without valves. We actually, in our practice, in our hospital, on the peak of the COVID-19 pandemic, we had a case of several false positive, PCR positive healthcare workers because the nurse who collected samples from the staff, she was infectious and she was using the valved respirator. So she contaminated the diagnostic material through this valve. It's important to understand. And also the very important thing to mention is respirator fit testing. This procedure is simple, and this is actually essential part of the personal respiratory program in healthcare settings. Without respiratory fit testing, we cannot make sure that all our staff can use safely the respirators. It allows us to find out if this particular model or size of respirators fit well for every our staff member. This is easy procedure, takes only 7-10 minutes. The qualitative respirator fit test costs only $200. US dollars. It lasts forever. It can be easily fixed on site. And I think it's very important to use the respiratory fit testing for all healthcare workers who work in high-risk conditions. Another very important thing was mentioned by Anita also is correct donning. In many cases, not just expensive or certified respirator or high-class protection respirator is important. If it's not correctly done, there is very high leak of infectious air in the breathing zone of the healthcare worker. The respirator doesn't provide any protection. So we have to correctly don the respirator. There was a very nice slides on correct donning of respirators. And there was a question about how can we find out about the certification of the respirators. In India, as I understand, you use the N95 certified respirators. This is US standard. And according to US standard and also European Union standard, EN 149, we should find on the package the written or pictured instruction on correct donning. I see Dr. Anita in her hands hold the package with the respirator with the instruction. This picture should show you how to correctly don this particular model of the respirator. The second thing on the face piece mask of the respirator, on the filter, you should find the model, the manufacturer, the class of protection, N95 or N99 or FFP2, FFP3, size, and standard against which the respirator was certified. It is a marked respirator. If you cannot find the class of protection N99, N95, or FFP2, FFP3, and standard, this is probably not certified respirator. Another thing is, again, the respirator fit testing.
Okay.
You should positively pass the fit test on this particular model. And again, I would like to address you to the ETTI website, TB Transmission Initiative website. On just Google ETTI Stop TB Partnership, and you'll go to the web page. You can see a lot of resources. There are very nice, very brief, pictured info sheet on respirators in English, in Chinese, in Russian, Spanish, French, and you can find very brief and concise information on respirators, more standards, models, choosing. Another info sheet is dedicated to the respirator fit testing, qualitative fit testing procedure. Again, it's included into WHO recommendations, the WHO guidelines published in 2019 and republished in 2021. And the respiratory fit testing is part of the personal respiratory protection program. It should be in place. About masking, also very important issue covered by Dr. Anita. So it was proven that in MDR-TB settings, high risk settings in South Africa, there was a study, and it was proven that if the contagious infectious patient wears the mask on during his staying in the enclosed space and poorly ventilated space, the risk for others to get the infections, to get infected, is being reduced by 50%, by half. It's not 100%, but it's a lot again. So it helps a lot to reduce the risk for others. And as it was correctly said, that masks and respirators are different things. Masks are mostly for patients to protect others. Respirators are for healthcare workers or people who reside in high-risk settings, and they are for protection of them from getting infection. And thank you very much for inviting me for joining your very good Airborne TB IPC webinar series. And I'm sorry that Paul Johnson, the CDC expert, and he was actually wanted wanted to participate, but he is a little bit sick and was not able to join for this last webinar of your series. Thank you very much, Dr. Anita, and all the participants.
Thank you, sir.
Thank you.
We'll pray for his speedy recovery. Thank you, sir, for your exploring new ideas and solutions and many facts. We never used to see the print on the cover while we wear it, but now it's a point to ponder that each one of us will see how much filtration is there and how much it's effective. It's all clear in the cover, but we never used to see it. I'm being honest in saying this.
Yeah, we have to understand that the respirator market is very aggressive. COVID-19 pandemic promoted production of many models of respirators in many countries and many manufacturers and so on. So we have to be aware of what quality of standard is used and is it safe to use this particular respirator on, because in every market in Russia, in many countries, I'm sure in India, there are some amount of fake respirators which do not provide good filtration and good seal for you, personally for you. So we have to check, we have to understand standards, and we have to pass the qualitative respirator fit test. Thank you so much.
Thank you, sir. Thank you, sir, for making us aware on this such an important point. So there's one more thing. Is there anything new innovations or any new technology in your country that in India we are not doing it right now, or we have not still inculcated in our program? Are you there, sir? Can you hear me? Am I audible, sir?
Mute.
Oh, I'm sorry.
Sir, actually, we wanted to know, is there any new innovations or any technologies that we are not inculcating in our program that you have in your country? Any new innovations other than what Sam has told right now?
I believe for future webinars, we could with support of ETTI and people from CDC and other groups, we could organize the webinar on upper room UVGI, little bit more detail. This is actually available technology, evolving technology, and it's cost effective, and it's not so expensive and complicated as a ventilation. But upper room UVGI, especially when it is combined with the air conditioning, like you have very hot weathers during this summer season, it helps a lot to reduce the risk. Also, the last advancement in UVGI is use of far UVC, shorter waves of ultraviolet, which can be actually used while all people in the room and they should not be shielded. This is in the development stage, but we could mention also this. So this is UVGI, maybe a very promising technology to be utilized in high-risk areas. And basically, I enjoyed very much your webinar, and your series was very informative and very useful. And because of that, ETTI decided to support, and we are happy to be part of it. Thank you so much.
Thank you, sir.
Thank you. UVGI.
Now we are moving on to the next session, that is question and answer session. Attendees here, please come out with your questions. Any questions you can ask here, or you can write in the chat box.
Chat में तो कुछ नहीं है ना.
You can write in chat box if you want. Please interact. Give an active participation. You can unmute yourself and ask questions. Please actively participate so that this session becomes very informative.
If anybody has anything to contribute, so they are also welcome.
Hello.
Hello.
Yes.
Ranjana.
Yes, Ranjan. Good afternoon.
Good afternoon, ma'am.
Good afternoon. Good afternoon, Ranjana. How are you? Yeah.
I'm fine, thank you, ma'am. Ma'am, as you said, we should not keep our N95 in the pocket, but we can all keep this mask in this paper bag
Yes.
before reusing.
Yes, yes, because these masks can be reused. So, like we made a policy at our hospital, at the time of COVID, because we didn't have that much supply. So that mask will be kept in the paper bag and it will be taken after a week. So that was but it should not be kept like in your pockets or somewhere else, but it should be in some paper bag and kept at a secure place.
Yes. Thank you, ma'am.
Any other query? Feel free to ask here anything, any doubt.
A very, 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 very good question. That any nurse involvement in healthcare policy making panel regarding this matter? This is George. Miss George, can I see you? This is very, 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 very important and core to my heart. That though nurses are the main persons who will be taking this infection control and all, and they are the main implementers. But see, I have seen so many airborne infection control guidelines made in the India at the Ministry of Health. But I have checked that list. Even not a single nurse was not there. Not only in airborne infection control, even in the TB programs, in the health making policy, I think that has to go to the administrators or the at the ministry level, that at least also they can also contribute, because they are the first hand providers of not only care, they are the first hand, and data also it will come from there. What are the issues, what are the problems, how this can be implemented. So I don't think till now I have seen any nurses involvement in healthcare policies. And I have gone through that airborne infection control guidelines that have been made at ministry. Even in that also I haven't seen. Even now just recently, because I'm in NITRD, so I came to know that Find is one NGO who is working for the TB care. They are also working at the airborne infection control project also. So they're training the people to have the risk assessment at various drug resistant DRTB centers of India. So in that list also, just because some doctors are my friends, I could see that only doctors are being nominated. Even from our hospitals, no nurse is being nominated for that, because nurses can do the risk assessment much better. So I think that issues has to be seen, and somehow the health policy people will be able to say it. What the Jidarji has to say, sir, what do you have to say about this? Because he is a doctor.
Can you see the question in the chat box?
Hello, ma'am.
Hello, please wait. Let the sir take this question also.
Our expert is going to say something about this.
Yeah, okay.
Sir, are we audible?
Can you hear me?
Yes, sir.
If I can, I would like to make an announcement that we just received notification from the Union Against TB and Lung Disease that in Bali, in World Lung Health Conference in November, will conduct together with ETTI and with Dr. Anita the full day 6-hour workshop dedicated to TB, IPC, and airborne IPC. And Dr. Anita will present personal respiratory protection and will conduct practical exercises about choosing respirators, donning respirators, respirator fit testing, caring, disposal, and so on. Many practical issues will be discussed. And thanks again, Anita, about agreeing to participate in this event in Bali, Indonesia this year. Everybody is welcome who will travel to participate in this conference.
But so their question is, why is there any nurses involvement in health policy in airborne infection control?
In my part of the Russia, nurses are very active. For example, for personal respiratory protection program, the coordinator and actually the key person for this program in the region is a nurse. Her name is Alla Bykova, and she is also leading light for International Council of Nurses like Dr. Anita. And she, by her profession, she is a bronchoscopy nurse, and she provides respirator fit testing for everybody, for myself including, on annual basis. And she provides training, education, and so on. And she provides some supervising and some development of signage about the using of respirators and so on. She's very, very active like other nurses and other components. And I'm a doctor, but for many years I worked in the hospital settings and outpatient settings. I do understand the importance of nurses. That in some cases, nurses much more important than a physician or a doctor. You understand that the closest person for the patient, and she have much more information in many cases, and she has opportunity to provide care when physician is absent. And also nurses are people who are actually at higher risk in many cases if they work with the contagious patients. So nurse we should not feel safe.
Yes, sir. Thank you, sir. Thank you. That nurses are doing it whatever they can do. That's okay. But when the political, when the top leadership will recognize it, that's the question. I think Sharon George, she would like to say something. Is she there?
Nurses advocacy and political movement and expert faculties in nursing education, in health policy education can be started from nursing school. Yes,
you can say something. She was about. Are you here?
Yeah, I can hear you, ma'am.
Yeah, please.
I was asking about any nurses' involvement in new health policies in respiratory diseases and disease controls. I heard that there is no nurses involvement right now. So we can start with a more expert nurses. We can do some higher education. We can do some researches, and everything we can start from the nursing schools. So they know how to involve and all.
Yeah.
So
I think I think it's a long way to go.
Yeah.
People here doing good work, so I think somebody someday will recognize and someday we will have
we can reshape our nursing profession at future, maybe.
All the best process.
Okay.
Thank you so much.
Thank you so much.
Any more questions? See, your questions will make this session interactive and informative too. There's one more question, sir. Dr. Volchenkov. Actually, I can see there are many air purifiers here, not in our hospital, but many of us I can see in shopping malls and very affluent families and wealthy people. But other than that, there is not much use here about regarding air filters. So, do you think there is any major help in that to reduce the risk of this respiratory infection? Does this air filters play any major role in that?
This is really a hot topic and very important area to discuss in this auditorium, actually within a broader auditorium. Just yesterday, ETTI released new newsletter is on choosing and using room air cleaners. And again, pandemic promoted a lot of this production in worldwide, and we should understand the effectiveness and role in reducing the risk. I would say in majority of cases, they are not quite effective to stay in the room, inside the room, unventilated room, if the risk is really high. And Anita, maybe you could share the newsletter with the nurses. And Paul Jensen wrote this editorial, and there is a very good chapter in the Curry Center TB Airborne IPC manual dedicated to these air cleaners. What should we understand very clear? We have to understand the technology. We have to understand the capacity of this particular air cleaner. We have to read specification. What is the clean air delivery rate? How much clean air this air cleaner can provide? And we have to understand what room we are staying in. We will use this air cleaner in this room. So we have to compare this air cleaner delivery rate and volume of the room. And we can easily calculate number of equivalent ACH. ACH is air exchange rate. So in high risk areas, we have to have at least 6 better 12 per hour. And most of the air cleaners, they're not powerful enough to provide such ACH in high-risk settings. And I would say that even slightly open window to provide some natural ventilation may be much more safe to stay in than to have a room air cleaner in unventilated, in completely unventilated room. So we have to carefully understand, assess the technology and understand that it can be effective if the room is small enough and the room air cleaner is well maintained and powerful enough, have enough capacity to provide high ACH in this room. So I just would like, maybe this can be the topic for one more webinar of your series in the future.
Yes, sir. We'll plan, sir. We will plan these air cleaners and this. I'll share the ETT newsletter also to them and the ETT website also. Today, in this today's session, we have shared the all links also so that anybody can have access to this. Shifa, have you shared that links? In chat box, the links are there about the ETT. You can go through that web page, and there's so many informations, as sir said, about the air cleaners, about the airborne infection control. So please go through those links and see. That's ETT website also. You can go ETT Stop TB Partnership. That also you, in the Google, if you will put, you will get that site.
Yeah, and continuing about air cleaners, we did an assessment of the effectiveness. In some settings, you have to install up to 48 or more air cleaners in the room to have a same level of safety as open window or good mechanical ventilations. So it's not just one, it may be several air cleaners, and even if they're simple to install and just to switch into the electricity socket, but it doesn't mean that they provide enough safety. We have to understand the risk, the technology, calculate the reduction of the risk and the ACH, actual ACH they provide. So we have to be careful.
Yes, sir.
Thank you.
Thank you, sir.
Thank you, sir. You made ma'am's presentation more comprehensive and impactful.
Thank you, sir.
Thank you. Thank you, sir. Thank you once again. I think there is no more questions for anyone. So we'll stop it here now. I think we have covered all the key points that we wanted to talk. Feedback. I hope you had all clear instructions on how to join this session. Step-by-step guide to join the link. I hope there wasn't any issue now because it's the 16th one. Okay, all of you have a great day. See you next month, last Friday, with a new topic.
The next topic will be HIV TB.
Next topic will be HIV TB.
Thank you very much.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thanks a
Thank you
lot.
for being an expert. For the feedback, put your questions in chat box.
Feedback.
We'll keep this session for 2 more minutes so that you can put your views in your chat box, feedback in your chat box.
Thank you, ma'am. Dr. Manpreet Valla. Thank you, Director ma'am, for being with us.
Thank you, Dr. Anita. It was a very informative session. And, also, Dr. Gregory, for his comments, gave the latest updates. It was really nice listening to all the sessions.
Thank you, ma'am.
Thank you, ma'am.